Welcome and thank you for joining us for our Research Tuesdays event, Rethinking Men's Health. I'd like to start by acknowledging the Kaurna people, the original custodians of the Adelaide Plains and the land on which the University of Adelaide's campuses at North Terrace, Waite and Roseworthy are built. We acknowledge the deep feelings of attachment and relationship of the Kaurna people to country, and we respect and value their past, present and ongoing connection to the land and cultural beliefs. My name is Olivia Bellis and I'm a PhD candidate in the School of Biomedicine here at the University of Adelaide. I'm also your MC tonight, where we will learn why men are dying younger and from preventable causes more than women. University of Adelaide researchers, Professor Gary Wittert and Dr. Sam Tafari are here to discuss the common issues that prevent optimal care for men and what tools they're developing to better these outcomes. Professor Gary Wittert has a personal chair in medicine and is the director of the Freemason Centre for Male Health and Wellbeing at the University of Adelaide and SAMRI. He's also a senior consultant endocrinologist at the Royal Adelaide Hospital, senior principal research fellow at SAMRI, and a fellow of the Australian Academy of Health and Medical Sciences. Dr. Sam Tafari is a graduate of James Cook University Medical School in Townsville. He undertook basic physician training at the Royal Adelaide Hospital, where he is currently a second-year advanced trainee in adult endocrinology. During 2024, he was an andrology and men's health fellow at the Central Adelaide Local Health Network, and he enrolled in a PhD that aims to improve primary healthcare for men in Australia. Please join me in welcoming our speakers to the stage.
Thank you, Olivia. Thank you, everybody, for coming along, and to Charlotte and the team for organising this. As you heard, I work at the Freemason Centre for Male Health and Wellbeing, which I direct, and I'm going to start just by telling you a little bit about the centre. We commenced in 2007, and we're multidisciplinary, multi-institutional, and have a translational focus. We have three main streams running down, so health service, system and service innovation, males in society, and chronic disorders, both physical and psychological, as well as cancer. And then on the other side, we look at basic science, biological determinants, ecological determinants, health equity, populations, we have community partnerships, and then a variety of platforms. This is the sort of idea of a pathway to translation. So we have different approaches. So you can see population and community-based studies, and I'm going to tell you about our cohort studies, the FAMIS and MALES study. We have clinical trials, basic sciences in the laboratory, which then lead to clinical trials, and workforce training. And these are the health problems that we're interested in. So disorders of aging, the chronic disorders, prostate cancer, mental health disorders, and prostate cancer. We aim to gain knowledge and then to use that knowledge to improve health outcomes. So this is a list of some selected health outcomes that has successfully been through this pathway and resulted in those sort of outcomes. The second thing I want to introduce you to is the fellowship program in andrology and men's health. So we recognized that there was a big gap in the provision of healthcare to men. And so we began this fellowship program in andrology and men's health 4 years ago. It's a 1-year clinical and research training program. We've had 4 fellows trained to date, one of whom you're going to hear from tonight, and a 5th commences in 2026. The program was initially funded by Bellbury, who provided us seed funding, and then subsequently for the last 2 years it's been funded by the Hospital Research Foundation, and then for the next 5 years, half of it, the money is coming from the University of Adelaide, and we need to find the other half. 3 of the fellows have enrolled in a PhD. 1 of our fellows already had a PhD, which gives you some idea of the quality of the trainees that we've had. And the sort of curriculum is learning to communicate with men and engage them in care, attending to disorders of mental health, disorders of testosterone production and function, chronic disorders and the lifestyle, environmental and social factors associated with those chronic disorders, erectile and sexual function, and importantly, how those things link to chronic disorders, lower urinary tract symptoms, moving away from the prostate and the bladder to these symptoms being a reflection of chronic disorders, infertility and assisted reproductive technology, and then prostate and testicular cancer, and particularly survivorship care. And then the trainees engage in a research project across 1 or more of these areas. So, health disadvantages of males. Well, men live 5 years less equivalent healthy life lived, and that hasn't changed over decades, despite a multitude of initiatives. Suicide is the leading cause of death in young males, 36%. In the age group 15 to 24, 24% in the age group 25 to 44. 60% of men with depression are undiagnosed. So it's not that the high prevalence of suicide is because men don't get depression and they just suicide. Men do get depression, but it's mostly not recognized. Coronary heart disease accounts for 65% of preventable deaths in men. 1 in 4 men aged over 65 in South Australia have type 2 diabetes. Men are less likely to be diagnosed with and get treatment for osteoporosis, but if they do have a hip fracture, then they're more likely to die than are women. Men are more likely to die of prostate cancer than women are likely to die of breast cancer, and they're more likely to be inappropriately treated for lower urinary tract symptoms, more likely to suffer with obesity, but less likely to receive treatment for it. There are particularly marked disparities in disease burden by men who live in rural and remote areas and in those men who live or who have Aboriginal heritage. Men who are Aboriginal Torres Strait Islanders have 12 years less of healthy life lived in Australia compared to any other men. And before reaching the age of 65, 53.4% of males and 32.7% of females leave the workforce. So almost twice as many males will leave the workforce because of chronic disorders. Now, we've been looking at chronic disorders and the causes of chronic disorders and progression of chronic disorders since 2002, when we started this cohort study, the Florey Adelaide Male Aging Study. We ran clinics between 2002 and 2005. And then subsequently we merged with another study called the Northwest Adelaide Health Study and formed the male study, which more than doubled the number of participants we had. So we had 2,600 men, all followed from 2002. And then we resurveyed the men between 2007 and 2010. So these were the follow-up clinics. And then in 2010, we randomly selected men to do a sleep study at home. So that was about 867 men. And we looked at a large range of things in addition to chronic disorders and medication use. So these are some of them that we looked at, and most of them I'm not going to talk about. And we continue to follow these men using data linkages, where we get information about health conditions, hospitalizations, death and causes of death. And what we found was an alarming burden of chronic disease. So overweight, 77% of men. Obese, that's with a BMI greater than 30, 33%, so a third of men. If you do this by waist circumference, greater than 94 centimeters, which is the overweight equivalent, that's 28% of men, and obesity greater than 102, 42% of men. If you use a cutoff of 100, then it's nearly half of all men. Between the 5 years of the two waves, the prevalence of diabetes increased from 10.4 to 13.1%. Symptomatic heart disease so angina, chest pain from 5.6 to 6.2%, osteoarthritis 8.1, 11%, and anxiety stayed about the same. Sleep disorders were extremely common. So insomnia, that's a sense of not being able to sleep adequately, 17%, and 41% had 2 or more sleep problems. So here are some of the sleep problems that we identified. So insufficient sleep, that means less than 6 hours a night, and that affected 10% of the men. And we found in the analyses that we did, this is what's called a forest plot. So anything to the right of this dotted line is increased. So they had increased blood fats, they had increased heart disease with symptomatic pain, so angina, an increase in symptomatic depression, an increase in previously diagnosed depression, an increase in prostate cancer, and an increase in sedative use, so that's not a surprise. If we look at shift work, so this is shift work for more than 3 years, higher blood sugar, higher blood fats, particularly this kind of blood fat called a triglyceride, which is linked to having high sugar. Again, we saw an increase in symptomatic heart disease, so angina, insomnia, not quite significant. And then men who did these, men who were shift workers were more likely to be in a trade, an apprentice, or have a certificate or a diploma compared to higher levels of education. And then lastly, obstructive sleep apnea. That's a condition where when you go to sleep at night, instead of your airway staying open so that you can breathe, it blocks up. A mild form of that is a snore, where you get vibration along the airway, and that is that snoring sound. But when the airway completely blocks, or if it almost completely blocks, and the oxygen level in your blood drops, that's called obstructive sleep apnea. And we can work out how many times an hour that occurs, and then grade it mild, moderate, or severe. So 52% of men over the age of 40 in the northern suburbs and the western suburbs of South Australia, broadly representative of all men, 52.9% had some degree of sleep apnea. So half of those, about half was mild. And then of those, about half again was moderate, and about half of those was severe. So 1 in 6 men have severe obstructive sleep apnea, as in, you shouldn't be on the road with me. And this condition has serious effects. So daytime sleepiness is one of them, but it only affects 15% of men with sleep apnea and doesn't relate to severity. Causes reduced quality of life, almost to the same extent as heart failure or cancer. If there's insomnia, then it's associated with depression. It's associated with worse blood sugars, chronic kidney disease, getting up at night to pass urine, heart disease, particularly atrial fibrillation, which is an abnormal heart rhythm, and the risk of stroke, increased blood triglyceride, sexual dysfunction, both decrease in desire and dysfunction of erections. It accelerates cognitive dysfunction and therefore dementia. All right, so let's get on to some secret men's business. Lower urinary tract symptoms and sexual function. And I want to show you how these are red flags for the chronic disorders that I've shown you and the chronic disease risk factors. So the low urinary tract symptoms I'm talking about are frequency, so going more than 8 times a day. Urgency, which means you can't wait, so you need to go urgently, or you have a sense that you might leak, and have incontinence. Nocturia is getting up more than once at night to pass urine. Those are all what we call storage symptoms. And then things like weak stream, after dribble, difficulty initiating urination, those are voiding symptoms, all right? So if you look at the storage symptoms, they're related to obesity, diabetes, obstructive sleep apnea, smoking and alcohol consumption, lack of physical activity, strongly associated with erectile dysfunction, heart disease, low HDL, so that's a good kind of blood fat, and it's low in association with that, and having inflammation, so any inflammatory disorder, strongly associated with depression. So if I had to ask many men, if they had these symptoms and you were over the age of 60, almost everyone would put up their hands, or most. And if I asked you if you thought it was your prostate, most people would say yes. And I'm here to tell you that mostly it's not. Voiding symptoms, if they're severe, are usually due to the prostate, but men with a large prostate need not have voiding symptoms. Men with voiding LUTs often have decreased hand grip strength, so tend to be more frail. Sleep apnea is very strongly associated, and erectile dysfunction is strongly associated. So it's not just an inconvenience, it's an indication of a serious and often remediable or preventable underlying health problem, and it can't be assumed to be due to the prostate. So if you look over a period of 5 years, LUTs doesn't stay the same. It can progress or it can remit, and about 1/3 goes in either direction. So 1/3 stays the same, 1/3 gets worse, 1/3 gets better. Well, what makes it get worse? So storage LUTs gets worse if you increase the amount of fat in your abdomen, if your blood sugar goes up, if you have obstructive sleep apnea getting worse, if you have low estrogen, usually following because you've got low testosterone, depression, and being widowed. Remission is more likely to occur in younger men if you lose abdominal fat, if your HDL goes up, if your sleep apnea gets treated, if your estrogen concentration goes up, if you have less anxiety and more physical activity. So it's preventable, remediable, and can improve. And similarly, voiding LUTs, with increasing attention to risk factors, particularly obesity and testosterone, sleep apnea, their improvement, and physical activity. So in people with obesity and storage LUTs, the future risk of heart disease or diabetes is doubled. So the message here is listen to your bladder. It may be telling you about your future health. So erectile dysfunction is the next topic. How often does it occur in men aged 35 to 80? And the answer is often. So the overall prevalence is 43%, 23% moderate to severe overall, and 60% moderate to severe over the age of 65. Now that compares to only 10% of men who lose interest in having sex. And most men are not asked by their general practitioner whether they have erectile dysfunction, but most men would like to be asked and have it addressed. What are the causes? Well, it's linked to heart disease, high blood pressure, blocked blood vessels, obesity, diabetes, smoking, alcohol, this is lack of exercise, mental health like stress, anxiety, strongly related to depression, and there are some medications. And also obstructive sleep apnea, strongly. And it predicts other disorders, so heart disease, stroke, diabetes, and depression. And the window is about 3 to 5 years between this increased risk of heart attack of around 46% and stroke about 35%. I want to switch gears now because having given you a background to the sort of problems and the sort of problems where you've got these red flags or what you might call canaries in the coal mine, let's have a look about health service use in men and what some of the pervasive myths are. Firstly, that men use health services less than women. They don't. Men are not disinterested in their health, and they're not neglectful of their health, at least not intentionally, nor are they reluctant to address health issues. And masculinity is not a problem. It's a myth that it's a problem. This is the national data on use of health services by males and females. So in the orange line is females, and in the blue line is males, and you might look here at this bump up here and go, but Gary, you're wrong, look at the females. They use health services more than males. Well, this is accounted for by the reproductive services gap, because what's happening here is women are getting health services for contraception, for problems with periods, for reproductive services, cervical cancer screening, breast screening, and then menopause. And you see the same thing with hospitalizations. And once you move out of that reproductive age group, you can see how many more hospitalizations are occurring for men than are for women. This is emergency department attendances. You see a same trend. And then finally, the criticism is, well, men delay seeking care. So here is data from the Australian Bureau of Statistics. This is 2023-24 data, and it shows the proportion of males and females aged over 15 that access healthcare in a timely manner, and it's women who are more likely to delay seeking access to care than are men. So we found when we looked at this that over 90% of men aged 35 and over visit their general practitioner at least annually. And the main reason was to go for medication for a disorder that they know they have, or they have a health crisis, or they're overtly sick. So they're less likely to go for screening, they were less likely to take children, they were less likely to go for preventative health care. They did go for regular checkups. Immunization wasn't a feature in this, and then there was another group. But when we asked if they were satisfied that their other health concerns had been attended to, 60% said no. So it turns out, in a series of studies that we did, that engagement with health services by men differs from women. And it cannot be assumed that current health services meet the needs of men, or that health service providers are equipped with strategies to engage men in discussions about their health. Men conceptualize health differently and balance priorities. They may be more concerned about role efficacy or attending to their jobs, so their efficacy as an employee, looking after their families, and maintenance of independence. Men tend to self-monitor, and the action they take is based on prior illness experience. Health literacy, very importantly, so how much they know and understand about their health, the perceived severity of the problem, relative priorities, which ties back to the previous box, and the accessibility of the service. When they ring up and they want to make an appointment, can they get in, or are they told to wait 3 weeks, or can they find a service that's culturally appropriate for them? Men have poorer health literacy than women. Masculinity is not an obstacle to care, and men will talk about their health in the right environment and if the conversation is appropriately facilitated. We need strategies to ensure that men receive more effective care. So we're interested in driving change by empowering men, because I'm not going to be able to tell general practitioners what to do. We need to enable men to take control of their health and well-being. We need to help improve men's health literacy so that they can make informed, confident health decisions, including how to act, when to act, and how to navigate the system. They need to have culturally sensitive and male-focused health services available to them, accessible, and the environments need to be appropriate, and the services need to encourage autonomy and trust. Services should be culturally competent, form therapeutic partnerships, use plain language, visual aids, and teach back to enhance understanding. So I thank my colleagues, and I'd now like to introduce you to Dr. Sam Tafari, who's going to tell you about how we're going to solve that problem. Thank you.
All right, so thank you, Prof, for setting the scene. And as he alluded to, I'll be touching on some of the work that we're doing to bridge that that communication and providing the care that men so desperately need. So the headline is that we know that men live shorter lives than women. They have a greater morbidity burden. They will use health services when they understand the reason to do so. And when they get to the doctor, they're not getting the communication or the care that they need. So we need men to understand when to seek care, how to navigate the system, and have enough information to have a productive conversation with their doctor. So just to set the scene for a bit of the work we're doing, at the end of my basic physician training in late 2023, I met with Prof. Wittert and we had a conversation. And Prof went, Sam, here's a great idea for a PhD. And I said, sure, what is it? He said, we know that men have lower health literacy. And I said, absolutely. And they don't get the care they need when they come to see a doctor. True. So why don't we change that with a checklist? My exact words. And the point was that we were going to ask questions, but we were going to teach at the same time. So the how, what we're proposing and how we'll do it. So the first thing you do when you want to solve a problem is you see what's out there. And that was where, as part of my PhD, we undertook a systematic review, which is largely done, but the interim results of which are that in the literature there's no evidence-based comprehensive tool for the use of any questionnaires in the pre-consultation setting. That is, we were looking at whether or not there were any checklist type items that have been used in primary healthcare to screen men. What we have seen, though, is that for similar tools that are very much disease-specific, there is a high degree of receptivity from patients, and that they have led to changes in test ordering and prescribing, and that they have led to improvements in the management of chronic health conditions. Now, these results suggest that going ahead with designing a tool for use in the sort of primary care setting, which men would sort of, fill out yes/no questions to screen for their health behaviours, symptoms and engagement with screening is a very valid approach and that nothing like this has been trialled before. This builds on the idea that men want to be asked things directly. They don't necessarily respond well to open-ended questioning, which we're often, as medical students, taught is the preferred style of communication. So it's building on that idea by asking questions directly in an opportunistic and time-effective manner. So this, in a way, makes us pioneers. So the next bit I wanted to touch on was as Prof. Wittert touched on, we have this great local data available in the form of the Adelaide male ageing study and later the males cohort. And as part of my PhD, we're also undertaking a retrospective cohort analysis. That is, we're taking the group of men and we've got lots of available data from this group of almost 1,200 men. And we're going back and seeing whether or not the presence of and we partly know the answer already, how the presence of erectile dysfunction and lower urinary tract symptoms can then be used to predict both your risk of disease today, but also your risk of disease in the future. So we know the FAMIS study was a group of almost 1,200 men, assessed at baseline and subsequently looking at the presence of lifestyle factors. We looked at disease data, medication use, and used a combination of surveys, electronic records, and pathology results to generate that information. And what we did notice was that there was a striking relationship between erectile dysfunction, lower urinary tract symptoms, and cardiometabolic disease and their risk factors, including death. What we did also note, which wasn't in the literature previously, was that erectile dysfunction and lower urinary tract symptoms, when they occur together, actually have an additive risk as well. So you have one or have the other, that's a problem. You have both together, that's even more of a problem. And there was a review that to this effect that Professor Wittert, myself and Professor Jessie Darson published last year, which got a bit of traction in the media. We spoke with Norman Swan and also did a local podcast. And this idea of using genitourinary symptoms to potentially be a predictor of disease risk is really gaining traction. And the point we're making, as Prof. Wittert touched on, is listen to your bladder and to your penis. It could be a sign that things are going wrong and a time to intervene. So this brings us to the main bit of the PhD project, which is developing a tool for use in that pre-consultation setting that men can take and both use to identify problems, but also to educate themselves. So what we were looking at is a 20-question checklist co-developed with the average Australian male, with questions spanning health behaviours, screening engagement, physical symptoms, and family history. We included questions on erectile dysfunction and lower urinary tract symptoms in particular, because as we said, they're strongly associated with cardiometabolic risk. But what we also know is that they're not routinely inquired about, And for men with erectile dysfunction, only 50% of men aged 40 to 49 sought medical advice, and this drops to only 25% of men aged 70 and over, people plainly just accepting it as part of ageing. And only 10% of men with severe lower urinary tract symptoms sought treatment, and about 1/3 have not even discussed it with their doctor altogether. Attached to this men's health checklist, we were also looking to generate something called the linked health information, which was, it's all well and good to have men identify that they've got a problem, but how are we going to educate them about it? And so this was sort of something that would be integrated together with the men's health checklist in the form of an app where you tick yes or no to a question or an answer, and then this would generate some information which myself and Professor Wittert put together, which was reputable, succinct, and would ultimately be tailored to men. And it would also provide links to reputable resources. So we generated the checklist and we generated the linked health information, but what we wanted to do next was then run it through a period of community consultation, and run it through consultation not only with men from this tool was generated with your typical Australian male, but we wanted to make sure that we were also getting out there to men from culturally and linguistically diverse backgrounds as well. So we undertook we had 7 different focus groups, each in a different language, and each group had about 10 to 12 participants. The languages we ran through, so we included men from non-Anglo-Saxon backgrounds, I suppose, for lack of a better descriptor. So we ran the groups in English, Dari, Arabic, Swahili, Hindi, Vietnamese, and Mandarin. And we ran them across 2 sessions. The first where we went through the men's health checklist tool, and we asked men about the appropriateness of the questions, the adequacy of the wording and translation, and the utility of the questionnaire. And the second was subsequently where we ran through the linked health information, and we asked men about the clarity of the information, the utility, and what could be added to improve the tool. So we've undertaken both. We've undertaken a thematic analysis, and we're currently going through the content analysis component. But some of the themes that came through in these discussions, firstly pertaining to the focus group, was that men wanted simpler, less technical language, and they wanted it to be very descriptive, and they didn't want us to necessarily use overarching headings. You'll notice a lot of this feedback seems very basic, but the idea is that whenever you develop tools for use in the primary healthcare setting to address health literacy, you have to remember these tools are often designed by highly educated people with good health literacy, largely written by doctors or other health practitioners. You really need to make sure that it's run through consumers and simplified so that it addresses the people who we're hoping to capture, which are people with lower health literacy and people who feel a bit left out. So men also wanted greater inclusivity. So they wanted it to cater to people with atypical schedules, people who work night shifts and so forth. They wanted precise quantities. So what is a serve of fruit or vegetable? They wanted a weight. They wanted a cup size. Including culturally appropriate activities. So it's all well and good to say sport, but often men for instance, from the Hindi community wanted dancing included as a form of physical activity. Where confusion existed, we simplified questions and repetitive questions were removed, and we included points on gambling and dental hygiene. So we had our focus group, and to give you an example of how we changed questions, we had, for instance, a question on whether or not men stretch or walk around during the day, especially if they sit a lot. Some people don't work during the day, and terms like stretch did not translate particularly well in several languages. So subsequently, we simplified it to do you move your body, and we specified that it was not only during the day, but whether you're working, gaming, watching TV. Do you snore heavily? Again, what does heavily mean? It's in the eye of the beholder. So we spelled it out. Do you snore loudly or stop breathing when you sleep? So we turned it into a sleep apnea screening question. And are you a shift worker? Again, what's shift work? So we again changed that to do you work night shifts or regular hours? So very common sense changes, but nonetheless important changes to make sure the tool works well. Then we went through the linked health information, and the general themes of discussion we were looking at the cultural fit and translation, we were looking at the language and literacy, and we were looking at motivational triggers. And generally speaking, men wanted, as far as cultural fit, they wanted, less technical terms, they wanted culturally familiar foods and activities, and they wanted us to incorporate challenges and risky behaviours, incorporated by migrants. For instance, the Arabic group wanted shisha, for instance, included rather than just smoking and alcohol, and alcohol was felt to be a less appropriate question. So, those are the sorts of changes that were proposed. Pertaining to language and literacy, people wanted plain instructions and avoidance of long lists. They wanted tables and graphics. They wanted us to define technical and medical terms, and there were a few translation issues that were pointed out and subsequently worked on. And as far as the motivational triggers go, well, there was very broad receptivity to the tool. Men responded very well once the financial, social, functional and health implications were made clear. And they appreciated the dialogue on mental health that was made particularly clear in the checklist and the linked health information. And just from our experience, in virtually every focus group, there was at least one or two men who went to go see their GP between the first and second focus group. So it did provoke a lot of thought and change in behaviour, even in our anecdotal experience. So to give you an example of what the checklist looks like, this is our just a page from it, very clear question answer, and some room for the linked health information there and then. And for an idea of what the linked health information looks like, again, just it's in different sections means different things, but lots of graphics. Try to keep the language simple, and in certain areas, men want a very clear instruction, such as with exercise. So we've included that as well, just to give a clear, a one-stop shop, for lack of a better word, source of information, and it is reasonably comprehensive. And the additional thing that we were hoping to get from this was that with each checklist the patient fills out electronically, they'll subsequently generate a list of prompts for a discussion with their GP. So not only have they identified in and of themselves that they've got a problem, not only have they learned something from the linked health information, but they've also then generated an output they can take to their general practitioner. So just as Prof. Wittert touched on, if we try and change the practice of general practitioners who we appreciate are time pressured and obviously have their own issues, and you're trying to change their practice, that's a battle that's going to take a long time to come to fruition. What is more effective, in my experience, and certainly in Prof's experience, is if you empower people with the information and let them know what the problem is, they can go be their own advocates with their general practitioner. And that's what this output does. So you can see here, it generates a little page here. At the end it says, I'm not getting my recommended amount of exercise, I'm having trouble with erections. That was the sort of mock-up example I gave. And then you can take that to your GP, you can arrange another appointment down the line, and you can run through these problems in more depth. So to give you an example of sort of a little mock-up app that we've generated so far, this is a little screen capture I did of one that we were in the process of working through. Well, we won't have the talking avatars, but the point being, we'll see. So you just tick yes, no. Got awkward ticking that one as yes with everyone watching, so I figured I'd. Okay. And voila, that generates, and then you take that to your GP. So that's just sort of a little concept. So we're still in the process of building that app. Certainly we'll still need funding to do that, so we're still looking at ways to facilitate that. And any generous donors out there, or any bright ideas that are out there, we're happy to take. So our vision is, as I said, to develop the app, to identify, educate and empower men to take charge of their health, and to help men to access health services in a way that meets their needs. And that's about it. So I'd like to thank everyone who's been involved in our work.
Thank you for those presentations, very interesting. So we'll now open up to question time, but I'll start with a couple of pre-submitted questions from online. So firstly, the first question is, what health messages are the government and industry sending to the population? Are they targeting women who usually push men to go to the doctor, or is the messaging for men?
So I don't think there's any deliberate intent to target one gender or another. I think the problem really is simply that the messaging is generic. And in reality, what our marketing colleagues know when they're trying to sell deodorant or hair care products or whatever, they will sell to men and women specifically. And I think health should be marketed to men and women in a very different way. So that segmentation and young men or older men and so on. So I don't think there's no intent, but there's a lack of sophistication about the approach.
Thank you. And the second question we've got here, are hormones related to why men are dying before women?
No.
No further comment. I'm a GP. Can you outline the key gaps in current preventative care guidelines for men that I should be aware of when seeing male patients? They usually come with a lot of input from their wives.
Yeah, I mean, not all men have wives, but sure, wives are important in men's health. Men who are married do better health-wise. But guidelines are not sex-specific. There aren't different guidelines for men and women, for example, when it comes to sleep apnea or cardiovascular disease, and there should be. There should be guidelines, or there are now guidelines for communicating with men in primary care. What the uptake of those is like, I don't know, probably not very good. Women are disadvantaged when it comes to obstructive sleep apnea and cardiovascular disease, and men are disadvantaged in different ways. So we really need sex-specific guidelines. My personal view is that we should put all of this in the hands of consumers with tools that they can take to their healthcare practitioners and be active participants in helping to manage the process.
Thank you. Now we'll open it up to the audience and to those that are online. So does anybody have a question? Yep, we've just got one back there.
A question from online is, which comes first, erectile dysfunction and LUTs or CV disease/metabolic disease?
So, well, they can come in either order, but the usual sequence that we see is that the erectile dysfunction or some loss of erectile function precedes the actual symptomatic cardiovascular event by a number of years. So it's a warning sign. Similarly, with low urinary tract symptoms often occur for a period of time before the onset of the diabetes or before there's a cardiovascular event. And if there's obesity, that's a magnifying factor. So these work with other risks. Do you want to add to that?
Yeah, so in our review that we published, we referenced some previous evidence where if you took men who had cardiovascular disease proven on an angiogram, on average about as Prof touched on, about 45% of them in the last sort of 3 years preceding their cardiovascular event had some form of erectile dysfunction. So certainly it is certainly at least a matter of sort of 3 to 5 years, if not earlier than that, you can start getting issues with erectile dysfunction that precede the cardiovascular event.
It's also true that treating erectile dysfunction prevents the downstream effects. Also, the earlier you treat erectile dysfunction, then the less likely it is to progress. Regular use of the erectile dysfunction medications, so the PDE5 inhibitors, have been shown to reduce mortality and also have some effects to reduce neurodegenerative diseases. So we actually think that general practitioners should ask men 2 questions. Are you getting up at night to pass urine? How many times? And then the second question is, are you having trouble with your erections? These don't take any time really. They're quick to ask. They don't cost any money. It's not an expensive test. It's cheap for the healthcare system, and it's a major factor in leading into the early detection of chronic disorders and their risk factors.
Was there any other questions from the audience?
I have another question from online, which is, if someone would like to get involved with your research as a higher degree research candidate, are there any opportunities to do so?
Yes, potentially. My email is easy to find, so I can be reached anytime just through the university email system. Yep.
And any more questions online?
Yeah, thank you for your presentations. I'm just wondering if you could comment on the role of alcohol consumption and what significance that plays in the men's health.
Yep. So the current state of play is that there are no benefits from alcohol consumption. The previous dogma that some red wine was good for your heart and some alcohol was beneficial is not shown to be correct. And the American Heart Association and affiliated bodies all now say that on their websites. When it comes to cancer, there's no safe lower threshold. So every drink you have starts to increase the risk, and it increases dramatically with an increase in the number of drinks that you have. It's also a major factor in disrupting sleep. So although you may feel it puts you to sleep, the quality of the sleep is much worse. And then that's why people don't feel as good the next day. So no benefit from alcohol, and it's fundamentally a cardiac and neurotoxin and causes cancer. So that's my position on alcohol, which is not a moral position, because if you make an informed choice to have some, that's fine, as long as people understand that. Binge drinking, so frequent consumption of alcohol, is a cause of erectile dysfunction and multiple other disorders. Alcohol in the evening can be a cause of erectile dysfunction, or if it's present, can make it worse. So it's not helpful.
And any more questions? Yep, Charlotte.
Question from online. This person says, thank you, great work. Also, how are you addressing the non-clinical underlying social and economic issues identified? Any thoughts?
So, look, the structural issues that are antecedents are almost impossible for us to address. But what we can do is understand how those factors influence health and target our care in an appropriate way. Now, that sounds like a cop-out. It's not really. The other important point that relates to that is I think people need to stop blaming masculinity for everything that happens to men. One of the big problems is this issue of depression that I mentioned. We could have done a whole Research Tuesday on depression in men and the fact that it's not recognized. Part of the reason it's not recognized is it presents differently. So irritability, for example, and aggression is not listed as a feature of depression in most of the diagnostic instruments that are used, nor is alcohol consumption or risky behaviors. Yet those are often the dominant characteristics of depression in men. So men may not recognize they're depressed, they somatize the symptoms. Now, why am I raising this about psychosocial issues is because men who are involved in a marital breakup are very susceptible to depression, and if there's any hint of a problem, then men get blamed for the problem. And there's frequently, when there's an issue of children, then men are on the back foot. Men are often lonely in those circumstances because the social arrangements are often organised by women, so they then find themselves isolated. But many men feel isolated anyway in the community or marginalised for a range of reasons, and that has significant health benefits. So there are a variety of initiatives to try and help men. So there are things like men's sheds. There are groups that get together and have meals. So there's a recognition and a groundswell of men supporting other men.
Yeah, and sort of briefly touching as well on what Prof said as those structural drivers, those structural socio sort of economic drivers. Obviously, we don't have as much leverage on, but we do know that men from lower socioeconomic sort of classes do have poorer, lower levels of health literacy, for instance, and that is something we can work on addressing. And certainly we are working on addressing, and similarly, men from culturally and linguistically diverse populations are also, again, a bit more disadvantaged. So the idea that we're working on addressing health literacy, and particularly addressing health literacy in those groups as well, is looking at, I guess, going one step down the line and seeing how we can correct the effect that has on healthcare engagement and health outcomes. So, we're not in government, we don't have that top tier power, but we certainly we're doing what we can in addressing the downstream effects. Yeah.
I think the information in the app, the app is very dense with information, but through the focus groups that we did with the different language groups, these men were very frequently socioeconomically disadvantaged or from cultural groups where they had very low health literacy and in some instances low literacy. And these are all focus tested reasonably well. And we got a lot of feedback to make the final versions even more user-friendly. We're now running a parallel project with an Aboriginal group of men to make sure that this is all suitable for Aboriginal and Torres Strait Islander people as well.
Just another question down the back.
Yes, over the years there's been a lot of discussion in women's health on hormone replacement therapy. As men are now actually surviving longer and getting older, and in order to stay older and fitter, is there any consideration to some level of hormone supplement replacement or whatever?
It's almost like I planted you there to ask the question. It's not normal for testosterone to decrease with increasing age. Now, that's a marked distinction to menopause in women, where a woman reaches a certain age and there are no more eggs produced by the ovary. If a male stays healthy, they will produce plenty testosterone right up until very old age, provided they stay healthy, they don't get obese or drink alcohol. So the low testosterone that might be seen in a 50 or 60-year-old male is a function of their health status and the medications they take and the health habits and health behaviours they have. So the way to preserve function, and that's erectile function and sexual desire and LUTs, avoiding LUTs and everything, it's the same answer for all of it. And while there are causes of low testosterone, genuinely low testosterone, that's not what the major factor is. And the notion of having routine hormone replacement for men in the manner that women have because they're getting older, it doesn't have any actual validity or necessity.
Another question from online is, I'm interested in the mental health questions you have included in your checklist. And you mentioned that men preferred no section headings. Can you expand on their reasoning behind this and how you structured the checklist?
So that's a great question. Look, we had about 2 questions mainly on mental health, and one was more or less a screen for symptoms of depression, where we asked an assortment of questions, whether they felt sad and irritable and things like that. So that was generally the depression screening question, and then the second question was regarding how they felt about their relationships and whether or not they had some anxiety about their relationships. And I suppose that's born from an awareness that you can have a depressive disorder in and of itself, or an adjustment disorder, or you can have situational factors and relationships which can be a major stressor, as Prof touched on, pertaining to men. We tried to spell out as much as we could their respective symptoms, rather than asking men overall, do you feel depressed? Full stop. Generally men have appreciated that that sort of wording. Very much we just tried to capture all the symptoms involved when we asked the question. As Prof Wittert touched on as well, we do know that depression obviously manifests differently and includes symptoms such as irritability, and I guess we've also touched on in the linked health information how to recognise problems with depression as well, which may manifest with sort of increased risky behaviour, alcohol use, withdrawal, irritability, and things like that. So we've very much tried to flesh out and describe the issues in depth and make them apparent.
Yeah, I mean, the questions on sleep, substance use, not just alcohol, but substance use more broadly, question on gambling, relationships, so that's interpersonal relationships, so plus the questions that Sam mentioned, that it's a little bit more direct, and then when the information, if they link to the information on those things, then the information about anxiety and depression comes up in each of them, as well as the link between depression and physical disorders. So depression, anxiety, and cardiovascular disease comes up, depression and diabetes comes up, depression, sleep disorders, and erectile dysfunction. So it's kind of woven in, rather than hitting someone on the head with the possibility that it might be that. And that goes to the fact with the groups that we were, the African people from Africa that we were working with, they don't have a word for depression. Aboriginal people don't have a word for depression. So there isn't any point in talking about it directly like that. You kind of have to talk about the circumstances where there may be something wrong and how they feel.
Thank you. I might just finish up with one last question from online, which I think is a convenient conclusion, which is, when is it likely the app will be available?
When someone gives us enough money to make it. is the honest answer. So the actual checklist and linked health information was funded by a grant from the Department of Premier and Cabinet, which was in part leveraged by some support from Sarah Game, who's very passionately keen about men's health, and it was a collaboration with Multicultural Communities Council of South Australia. We are talking to all of those people about how we might get this funded, but we also have to align with the National Digital Health Strategy, the Strategy for Primary Healthcare, and with a number of other government agencies. So any of you that have influence, capacity, or you can write code, let us know. Thank you.
Okay, so we'll just wrap it up there, and I'd like to thank once again tonight's speakers, Professor Gary Wittert and Dr. Sam Tafari. And thanks to our audience for watching in person and online, and be sure to sign up to our mailing list to receive information about a future Research Tuesdays series at the new Adelaide University. The QR code for the sign-ups is behind me. And thank you for a great year and have a great night.